Stomach sleeping with one knee raised. Every sleeping position has distinct effects on muscle growth and joint alignment. Sleeping face down with one leg pulled up creates asymmetrical pelvic rotation and continuous biomechanical distress. This stance forces the lumbar spine into lateral flexion and uneven axial rotation throughout the entire night. The erector spinae and quadratus lumborum muscles on one side remain chronically shortened, while the opposing side is stretched under continuous passive tension. The cervical spine is forced into extreme lateral rotation beyond 70 degrees, simply to allow an open airway. This persistent rotational torque places asymmetrical strain on the levator scapulae, upper trapezius, and cervical vertebrae. Chest compression directly against the mattress limits full diaphragm expansion during deep slow-wave sleep. Restricted oxygen intake reduces parasympathetic tone during the initial non-REM restorative sleep phase.
Peak pulse secretion of human growth hormone is compromised when deep sleep continuity is broken by minor asphyxial microarousals. Tissue repair in damaged skeletal muscle fibers is delayed due to altered systemic arterial perfusion. Over prolonged periods, this habitual posture causes chronic lower back stiffness and persistent pelvic tilt. Understanding how each sleep position affects recovery is essential for muscle hypertrophy. Full prone position. Sleeping completely flat on the abdomen requires maximum sustained cervical rotation to maintain airway patency. Holding the neck rotated at nearly 90 degrees for 6 consecutive hours strains the sternocleidomastoid and suboccipital complex. This persistent structural angle compresses the vertebral arteries and restricts cranial blood flow toward the brainstem. The lumbar spine falls into forced hyperlordosis due to gravity pressing the abdominal cavity into the mattress. Intradiscal pressure in the L4 and L5 lumbar vertebrae increases by up to 25% compared to neutral standing position. The anterior rib cage is mechanically immobilized by body weight, raising respiratory effort by 14% during sleep. Assisted lymphatic drainage of cellular debris from intense strength training is slowed by restricted venous return. The central nervous system remains in a low-grade sympathetic stress state due to elevated breathing resistance. Chronic prone sleeping destabilizes anterior shoulder ligaments as the arms remain elevated above the head.
The hyperflexed fetal position. Curling tightly into a ball forces the entire vertebral column into continuous spinal flexion. The thoracic spine remains rounded while the chin is pressed firmly against the sternum. This position stretches the posterior longitudinal ligament and erector spinae aponeurosis beyond their natural resting length for hours. The intervertebral discs experience backward hydraulic pressure, pushing the inner nucleus pulposus posteriorly toward spinal nerves. Deep diaphragmatic breathing is mechanically restricted by the hip flexors compressed tightly against the lower abdomen. Reduced tidal volume during sleep lowers systemic tissue oxygen saturation during crucial metabolic repair windows. Venous return from the lower extremities is impaired due to acute flexion angles at the hip and knee joints. Accumulated metabolic byproducts like lactate, hydrogen ions, and serum creatine kinase remain in muscle tissue longer.
Spinal stiffness upon waking is the direct result of prolonged disc hydration under flexed compression. This chronic flexed posture reinforces poor standing posture, deepening thoracic kyphosis over time. Side sleeping with arms under pillow. Positioning the body on one side while tucking the lower arm under the head induces severe neural and vascular compression. The weight of the skull and upper torso presses down on the humeral head, trapping the brachial plexus nerves. The supraspinatus tendon is compressed directly against the acromion process in an anterior elevation angle. This sustained structural impingement restricts microvascular blood flow to the rotator cuff tendon insertion. Numbness and tingling in the fingers indicate transient neural ischemia along the median and ulnar nerve pathways. The unsupported upper leg falls forward, twisting the lumbar spine and placing rotational torque on the sacroiliac joint. Unbalanced spinal alignment creates uneven muscular tension along the tensor fasciae latae and gluteus medius. Frequent microarousals occur when nerve compression triggers involuntary spinal repositioning.
Over time, this posture initiates chronic shoulder bursitis and persistent rotator cuff tendinitis. Right side lateral position. Sleeping on the right side maintains acceptable spinal alignment when supported by an adequate anatomical head pillow. However, right side decubitus alignment compresses the inferior vena cava against the posterior abdominal wall. This mechanical pressure reduces venous return to the right atrium, slightly lowering overall cardiac stroke volume. The anatomical position of the stomach remains elevated above the lower esophageal sphincter. This orientation allows stomach acid to pool near the esophageal junction, predisposing the body to nocturnal acid reflux.
Subclinical acid reflux disturbs sleep architecture without necessarily waking the individual completely. Glymphatic clearance of metabolic waste through the central nervous system operates at reduced efficiency on the right side. The upper shoulder tends to collapse forward, placing mild passive tension on the pectoralis minor and anterior deltoid. Muscle protein synthesis efficiency declines when overall sleep quality is degraded by micro-reflux events.
Left side position with knee support. Sleeping on the left side with a firm contoured pillow placed between the knees optimizes multiple biological systems. The knee pillow maintains neutral pelvic alignment and prevents internal rotation of the upper femur. Lumbar spinal torque is reduced to near zero, fully relaxing the quadratus lumborum and piriformis muscles. Left side alignment places the stomach below the esophagus, preventing acid reflux and gastrointestinal disturbance. Venous return through the inferior vena cava is unimpeded, maximizing cardiac output and systemic oxygen delivery. The glymphatic system operates at peak physiological efficiency, clearing neurotoxic metabolic waste from the brain. Unrestricted bronchial pathways support maximum tidal volume and steady arterial oxygen saturation throughout the night. Parasympathetic dominance is maintained, allowing uninterrupted release of human growth hormone during deep sleep cycles.
Joint capsules in the hips and lower back experience minimal passive strain, reducing morning stiffness. Flat supine position. Sleeping flat on the back without knee support distributes body weight evenly across the sagittal plane. Spinal alignment remains symmetrical, eliminating rotational shear forces on intervertebral discs and facets. The cervical spine rests in a neutral posture if the pillow height matches the natural neck lordosis curvature. However, fully extended legs maintain continuous passive tension on the iliopsoas muscle group. Tight hip flexors pull the lumbar spine forward, creating an exaggerated arch and lower back tension. Gravity causes the tongue and soft tissue of the pharynx to collapse backward, narrowing the upper airway. Increased airway resistance leads to heavy snoring and transient hypopnea events that fragment sleep architecture. Microarousals from partial airway obstruction impair the transition into deep stage 3 slow-wave sleep. Restricted deep sleep duration directly reduces nighttime muscular repair and nervous system recovery.
Supported supine position. Sleeping on the back with a contoured pillow under the knees is the biomechanical gold standard for muscular recovery. Elevating the knees 15 to 20 degrees slackens the psoas major and flattens the lumbar spine flat against the mattress. Intradiscal pressure across the entire spinal column drops to its lowest possible physiological level. The chest cavity expands without structural restriction, maximizing lung volume and arterial blood oxygenation. Blood flow to fatigued skeletal muscle tissue reaches maximum velocity due to unimpeded vascular pathways. Symmetrical weight distribution prevents localized pressure points and neural compression throughout the night. The central nervous system shifts fully into parasympathetic dominance, stabilizing heart rate variability. Deep, slow-wave sleep duration is prolonged, maximizing biological adaptation, cell repair, and muscle protein synthesis.
Optimizing spinal alignment and arterial flow during sleep creates the ideal environment for tissue regeneration. Your body does not rebuild muscle during the workout. It rebuilds when spinal torque reaches zero and biological adaptation begins.